Hi, I'm Dr. Mark Fryman, the Chief of Hepatobiliary and Pancreatic Surgery at St. Joseph Medical Center here in Towson, Maryland. Today's tutorial is on colorectal liver metastasis. Colorectal liver metastasis is essentially when colon cancer has spread or metastasized to the liver. So I'd like to go over a little bit of the anatomy first. This is a drawing of the liver, and we're going to call this the portal circulation. And this is a portion of the colon, or what's called the large intestine. And colon cancer originates in the large intestine, and that's the reason why it is now recommended that people begin having their colon screened by colonoscopy at age 50. So if you haven't done that, please go ahead and get that taken care of. Call your doctor to get that scheduled. And that's a way of certainly preventing or catching and diagnosing colon cancer at an early stage. But for those situations where the colon cancer actually grows to an advanced stage, it gets into the bloodstream mostly through the portal circulation, and this is the portal, and metastasizes or spread to the liver. And the topic that I'm going to talk about today is how do we manage patients who have colon cancer who has metastasized and spread to the liver. And the reason we're aggressive with this subset of patients are a fewfold. One, autopsy studies have shown that patients who have had their colorectal metastasis, most specifically in the liver, removed, quite frequently have no evidence of disease in any other location. In other words, it is possible that the liver is the only place where colon cancer would spread. It's not always the case, but it certainly is the case in a large majority of the people. And having said that, there is a great volume of retrospective data to show that it is certainly a worthwhile venture to have colon cancer treated in the liver. So as I mentioned, there are a large series of retrospective data. There is no current level 1 evidence or randomized prospective trials, and because of the great volume of retrospective data, and because of the fact that it is probably at this point unethical to subject people or patients to having no surgery at all, for those reasons we're not going to see a prospective randomized trial. Unless something changes where the chemotherapy is so strong that it takes care of these cancers and there is no role for surgery. But nonetheless, over the past 20 years or so, there are thousands of patients who have had treatment of metastatic colorectal carcinoma, namely liver resection. And the number that consistently comes up in these retrospective studies is survival that's greater than 30%, and somewhere in the 35% range in the earlier studies. And now with the advent of some more successful chemotherapeutic agents, we're actually seeing retrospective data where 5-year survival is in the 50% range in patients who have had treatment for metastatic colorectal carcinoma. So that's actually incredible survival, certainly when we're dealing with patients who already by definition have metastatic disease. So what is liver resection or liver-directed therapy and all this? And I'll go through all of this. This is the liver, and the liver actually has 8 segments, and we can draw these. That's 2, actually 3. Segment 1 is called the caudate lobe, and it actually is under the liver. That's segment 1. This is segment 4. Four has segment 4A and 4B. This is segment 5, 6, 7, and 8. And the right lobe of the liver is segments 5 through 8, and the left lobe of the liver is 2, 3, 4, and the caudate lobe is more towards the left, but there are some portions that are actually on the right, so this is combined. And the reason there are 8 segments is that each one of these segments actually has its own blood supply and drainage, as well as its own biliary radicals. So these can independently survive based on the anatomical distribution of both the arterial, venous, and biliary system. And the reason it's important is because the liver is so anatomically defined, it allows us as surgeons to also anatomically remove segments of the liver. So when patients have colorectal metastasis, there is a variety of ways in which they can present. Some patients present with what we call synchronous disease, which is at the same time as diagnosis of their colon cancer, and then there is a subgroup that have what's called metachronous disease, which is at presentation of the liver metastases at greater than 12 months since diagnosis. So synchronous and metachronous, when patients are diagnosed with colon cancer, before colon surgery, a full metastatic workup is done, and the patient is staged, and it is determined whether the patient has synchronous metastatic disease or not. Nonetheless, in patients, so patients present synchronously or metachronously. The other manner in which they present is with respect to the amount of disease. Do they have solitary lesions? Do they have multiple lesions or tumors? Are they isolated to a particular segment? And so forth. And in the past, it used to be said that the cutoff for resection was, less than 4 tumors, and that you had to have greater than 1 centimeter margin of resection, which is the area around the tumor. But now we're more focused on, can you achieve clearance of the tumors in either 1 or 2 phases with the help of chemotherapy to shrink it. So we're more lenient, and we're more aggressive, and we're more tolerant, and we're more willing to perform liver clearance in not just 1 stage, but sometimes even in 2 stages. So let's take this particular case, for example, where a patient presents with 2 lesions. And let's say that the patient presents metachronously, that this patient had chemotherapy for 6 months after the colon surgery, and that these tumors were picked up on routine surveillance over a year out. At this point, the option is to proceed with either more chemotherapy or to go directly with liver-directed therapy or surgical resection. And in this particular case, we're saying that there are 2 tumors in segment, 2 tumors, one in segment 6, one in 7, and they both can be removed by what's called a segment 6-7 or a right hemihepatectomy without much difficulty. It is well known that up to 75% of the liver can be removed at one time if there is an adequate remnant, or what's called the future remnant. And this is another potential scenario where you may have one large solitary tumor taking up the majority of the right lobe of the liver. And in this particular case, a right hepatic lobectomy, or formal right hepatic resection, where the blood supply just to the right side is taken, can be performed. Left-sided resections can be performed, and the most aggressive operation is removing about 70% or 75%. It's called a right trisegmentectomy or left trisegmentectomy. Right trisegmentectomy is extension of the right lobe of the liver to the left side, and left trisegmentectomy is vice versa. So clearly, resections can be done in an aggressive manner.